So I will talk about the landscape in the UK, but make it relevant for an international audience, because I think a lot of what we need to consider in this space is relevant across different health systems, but our approaches may vary depending on the needs of our populations. So first of all, what is early age onset colorectal cancer? It's a rather arbitrary term. It's typically usually defined as someone who has a diagnosis of colorectal cancer under the age of 50. But you know, if the ages that people are getting cancer changes, then is it still, you know, somehow unusual to be diagnosed under 50? Essentially, it refers to a population who are young when they're diagnosed. You know, around about 5% of all colorectal cancer. So they're still an outlier population. And why does it matter if it's only 5% of the population? Well, it's because in England, the bowel cancer screening programme now starts from 50. It was 60, so we brought that starting age down. In other countries, it's 45. But essentially, most of this population are below the age of national screening programmes when they initiate. They're often attending the GP several times, and the referral with symptoms is often delayed more than in older people. And this is a real challenge for primary or secondary care. If you're a GP in England or in the UK, you will have one patient with colorectal cancer being diagnosed every year within your population, and probably only one patient who's diagnosed before the age of 50 over your entire career. So how do you pick out that needle from the haystack? That is, you know, that's not an easy, there's no easy answer to that. And you know, education may be part of that, but really the main part is how do we help primary care identify these patients? What tools do we have? People are diagnosed earlier in life. There may be more to gain in terms of quality life adjusted years, but also they have to then live with that diagnosis and the consequences of treatment for longer. So if we think about the epidemiology just for a moment, so under 50 is, you know, 5–6% of the whole population diagnosed with colorectal cancer annually, and it's similar across the world. And that's about, in the UK, just over 2,600 patients every year. And if you think about the age distribution under 50, you know, most are between 40 and 49, but a good proportion between 30 and 39. And below that age, it is extremely rare. One of the reasons why this is topical, as I'm sure you have encountered, is that the trend in terms of incidence has been increasing in this population over the last few decades, both in males and females, and this is rising steadily. I think that this is in the context of the incidence of colorectal cancer after the age of 50 decreasing. So why is it increasing in younger people but decreasing in older people? Obviously, screening may have something to do with that. But why do you think the incidence of colorectal cancer is increasing in younger people? If you could go onto Slido and provide your answer. Is it because there's an increasing, you know, prevalence of obesity in the population? Is it because our diet is poor? You know, it contains a lot of processed foods, for example. Is it because of microplastics, which seem to be everywhere? They're on the moon, you know, they're in space, they're everywhere, at the bottom of the ocean, and they're certainly going to be in what we're consuming. Is it because something to do with genetics and the interaction of genes in the environment, or do we really have no idea? And it's, you know, it's okay. Any answer is acceptable. So we'll just give that a moment, and maybe we can show the results, please. So around half people think it's their diet, and my answer is I don't think I really have any idea. I don't think we've got any evidence about what the cause is that's really particularly meaningful. And that is one of the issues with this population, is that the quality of the data that we have to understand these issues is very poor. So I'm definitely in the no idea camp at the moment. Although obviously things that cause colorectal cancer in older people are likely to have an influence in the younger population. Actually, specific studies to evaluate these risk factors have not been undertaken in younger patients. And you know, there's a school of thought which is, okay, these people are getting colorectal cancer at 49, they were getting cancer at 52, but now because of diet and lifestyle and environment, it's just they're getting it a little bit earlier. But actually, that's probably not the case. Actually, the biggest increase is in younger patients. So this is the birth cohort effect. So most people who are getting colorectal cancer in their late 40s, maybe a lot of them were getting them, slightly later in life. But most of the increase in incidence is actually in people in their 30s and early 40s, where it's not the adjustment necessarily of people who are getting them after 50 that's responsible. So this birth cohort effect implies that maybe there was something in the environment which is altered, which means that our risk of cancer has increased. Now, what is the etiology? What are the potential etiologies? If you take the whole population and you offer a gene panel test, as we heard about in the last session, you'll find genetic cause for early onset colorectal cancer in about 16 or 17% of younger people. Let's just say if you had a slightly better panel that maybe you would explain maybe 1 in 5 cases, about 20%. And there are other risk factors that we know are important, like a personal history of inflammatory bowel disease and some environmental risk. But are all the other patients where we don't have an explanation, are they all outliers for risk? Is there some single strong risk factor that is leading to the cancer diagnosis? It's a big, we don't know actually. So what do we know about pathogenesis in the younger population? Well, we know that the role of the microbiome may be important. For example, there's a gene island, which is an E. coli and other bacteria like fusobacterium, which are important in colorectal cancer etiology. And this PK operans island produces a protein called colistin, which is a carcinogen, colobactin, sorry, which is a colobactin, which is a carcinogen. And this produces a gene signature SPS88, and specifically a particular mutation in the APC gene. I mentioned the birth cohort effect. Is it something to do with maternal obesity, blame the mothers, C-section, blame the clinicians? Is it something to do with antibiotics and the use of earlier, more frequent use of broad spectrum antibiotics? Probably all these things actually do have some influence on that pathogenesis. And then there's some work from, there's a genome-wide association, a Mendelian randomization study on just over 6,000 early onset colorectal cancer patients, meta-analysis that's identified some genetic loci that may be linked to risk. But essentially the genetic background in the population will have remained stable, largely speaking. So it's not like we can say there's an increase in the prevalence of a genetic condition, because that was already there in the population. And then when you see this being discussed in the news, this is a headline from the Guardian, experts say alarming projections stem from surge in obesity, poor diets and physical inactivity. I mean, this is frankly a nonsense headline, because this was referring to a paper that talked about the increase in mortality in younger people. And the paper did not address issues of obesity and diet whatsoever. However, it often gets reported in this way, and many patients feel that they're being stigmatized. And many of the patients that we maybe look after, that you are diagnosed under 50, you don't necessarily look at them and think, gosh, they have a really terrible lifestyle and they've brought this on themselves. And I think, how bad would your diet have to be to get colorectal cancer under the age of 50? I mean, you would have been, having to eat really badly from the moment you were born and smoke 80 cigarettes a day. I think we should stop blaming people under the age of 50 for their diagnosis. And this is unfortunately what comes across in how the media represents us, but also we as clinicians, when we're asked to comment about this, people often do refer to these issues. So I think we have to be careful. And we ask patients, this is one of our patients, Andrea Robson from St. Mark's, who had inflammatory bowel disease and was diagnosed with cancer early in life. And she's giving this quote as part of a survey that Bowel Cancer UK undertook in patients who were diagnosed with colorectal cancer at an early age. And this report was published in 2020. And a lot of the issues that are important to this population, I think we need to really tackle head on as clinicians. People are not aware that this is an issue in younger people, and really it still is a rare disease, essentially. But this is also something that people need to consider, GPs and also people who have symptoms, that actually you need to be aware that perhaps this is almost certainly not going to be related to a cancer diagnosis, but you cannot completely rule that out either, and that you should seek advice if you have symptoms. 4 out of 10 people had to visit the GP 3 or more times before being referred for tests. Like I say, GPs, it's an incredibly difficult challenge for them, so how can we make it a bit easier? And this is another patient describing their experience of having to go to the GP repeatedly before being referred. But I have a lot of sympathy with GPs, and because they have to manage diabetes and heart disease and everything else, as well as this very rare condition for them. So if we think about how we manage this within our health system, well, what are our thresholds for intervention? They're different in the UK than they are in the Netherlands, in the US and Australia and other nations with developing economies. Perhaps have different priorities. But what are our thresholds for intervention? They're not the same in every country. What's the absolute risk here? It's a low absolute risk. The relative risk is increasing, the incidence is increasing, but it still remains a relatively rare disease. And we have to think about how we utilise our resources most effectively. It's a rare issue for GPs, as I say, so we have to make it easier for patients to navigate that pathway from having symptoms or not having symptoms to making an effective and efficient diagnosis of colorectal cancer. What about symptoms in younger patients? And this is a meta-analysis of symptoms in early onset colorectal cancer. Well, more of the cancers tend to be in the distal colon, so more of them will present with something like PR bleeding than perhaps in older patients. But essentially, it's the same sort of mix of symptoms, by and large, maybe a little bit more in terms of distal colonic disease. What tool can we offer? Well, this is a subgroup analysis from the NICE-FIT study, which was led by Mutia Abulafi, but this is a study that we published a few years ago now, looking at the use of FIT in symptoms in younger patients. And essentially, if you use FIT and symptoms together, that's a much more useful tool for primary care to know who should be referred for an investigation like a colonoscopy, for example, compared to symptoms alone, which are really rather unreliable. In this population, 1.5% of symptomatic patients had colorectal cancer, people who had symptoms before 50. But these are patients where the GP already had a suspicion that there may be something going on. In a more broad population, this is a paper from Sally Benton whereby they did FIT testing in younger patients with any symptoms, even low-risk symptoms as they were previously called. The population prevalence of colorectal cancer is very low. It's at 0.38%. But FIT alongside symptoms, once again, really helps GPs. But how do we find the needle in the haystack? How do we risk stratify? We need better methods of identifying who's likely to benefit. FIT is not all of the answer by any means. And it may be that we need to address this in the younger onset population alongside other biomarkers. That means we can utilise our resources more effectively so that we're not referring lots of people with low-risk symptoms who are very unlikely to have colorectal cancer. We have to get something a little bit better than what we have at the moment. What other biomarkers are there? 16S RNA sequencing from FIT kits is promising. It's probably reasonably cost effective. And we have to think holistically. Like, this patient is unlikely. They're more likely to have IBS as a primary cause. And we have to think about IBD and how do we address that. If you're under 40 in the UK, you should be offered a gene panel test if you have colorectal cancer. If you're any age, you should be offered testing of the tumour to see whether or not you have Lynch syndrome. I believe we should be offering a gene panel test to anyone under 50, but and in some countries and some health systems that's what's offered. But people often don't get a genetic diagnosis until very late, and it's a problem. Definitely not just a problem in the UK. And we've had a national programme to try and address this in the UK. I know for a fact that actually it's a problem that exists in every health system in the world, identifying people who are at high risk and who should be offered a genetic evaluation, and for whom it can change absolutely everything, including their oncological therapy. If we think about then how they are treated, then we need to be offering systematically germline and somatic, so tumour panel molecular testing, because this personalises the care, it improves outcomes in people diagnosed with colorectal cancer. We have to think about how we manage the complex cases, the younger patients who maybe need an exanteration performed by Elaine Burns. Yes, there are more qualities to be gained, but then when people are getting through the cancer diagnosis, what consequences do they need to live with? And we'll hear about that, I think, from Gabrielle in a moment. One of the reasons why this is of interest to me is I was involved in this international early onset colorectal cancer guideline that was published. And one of the things that really struck me about this guideline, this is a list of uncertainties. where we don't have any evidence base. I would say actually for all of the guideline there wasn't really great evidence. And we had a meeting a few weeks ago in Newcastle of 48 academics from 4 nations in the UK, which was sponsored by all these societies and Cancer Research UK and whatnot. And we've established a consortium to address the research needs in this population, focused around the working groups linked to risk evaluation, diagnostic tools, treatment, and qualitative outcomes in the long term. Thank you.